right? So I will be dealing with the theoretical part of assessment, the different methods, the different ways by which we do mental health assessment. And in this, we will be talking about history taking, history collection, mental status examination, mini mental status examination, and neurological examination, and some psychological test. All these methods are used to assess the mental health of any individual, to diagnose certain mental disorders. Let us just, these all are methods, these all are procedures which are practically done to rule out the problems and the disorders. So in this video, in this circumstance, in this situation, we can only talk theory about the theory of these topics. And as especially neurological examination. For neurological examination, we will be needing certain equipments to perform, to demonstrate. So I will be dealing with the theoretical part of these procedures. So let us begin with the history taking or history collection. First of all, let us just think that why do we collect history, or what is the importance of history collection and when it is done. So whenever a patient come to the hospital, whether it is in emergency department or in the outpatient department, whenever the patient comes to the hospital, history collection is the first thing which is done. Collecting history, talking to the patient about his disease, talking to the past problems and how the disease started and what all things occurred. So this is the first thing which is done. Collecting history about his disease condition, talking about his chief complaints. Okay, say there is a patient come to you in the OPD, and for what first thing you will ask, or what first thing you will do? You will start asking, okay, what is the problem? Why did you come to the hospital? Okay, now the patient will tell you, okay, I am having suppose say patient says that I cannot sleep properly. Then you will ask in further, you will ask in detail, okay, from how many days you are experiencing this, okay, for how many hours you are able to sleep, whether you are not able to sleep because of any physical problem or not. So all these questions you will ask, and you will try to gather as much data as possible, which will help you in the treatment plan, which will help in making the diagnosis, and which will help in reaching to a decision, to a point where treatment can be discussed and can be planned and can be implemented. So history collection is the first part, is the basic part, and it is a very important tool, very important component in the treatment, because without detailed history collection, without detailed information about the patient's disease, the treatment cannot be planned properly. In history collection, there are certain steps, there are certain parts. We will be discussing about them one by one. First is identification data. Identification data is one of the important thing, and this is the first thing which is done in the history collection. In this, name of the patient, patient's gender, patient's address, patient's age, patient's occupation, marital status, patient's religion, and patient's dietary habits, all these things are collected. Why? Because we should know the age of the patient, because age also has age is also one of the factors when we consider the etiology of the disease. Okay, then gender is important to be noted on the paper, and then it is about the occupation, the educational status, to know the how much, how till which standard the patient is educated or not, whether he is able to understand the language which I am speaking or not. Okay, and marital status, whether he is married, unmarried, and then the family dynamics is assessed on the basis of a marital relationship only, and then talking about how many kids he or she has. Talking about dietary habits, whether the patient is vegetarian or non-vegetarian. This will help you in making the plan for making the or psycho educating the patient about the diet, about the balanced diet. because you will be telling, you will be teaching about those diet only which are the preferences of the patient. Okay, and then we talk about the informant. We talk to the patient also, and we talk to the informant also, to the family member also, the one and anyone who's accompanying the patient. And in case of psychiatric patients, mentally ill, it is most of the time it happens that patient is not in the condition to talk about himself, because he is not in his senses, or maybe he is not oriented, maybe he's not he's very aggressive or violent. So in all these conditions, most of the time this happens that history is collected from the person who is accompanying the patient. That may be a family member, that may be a friend, that may be a relative too. So informant, what is the relationship of the informant with the patient? Because if suppose there is a family member, then we can expect a reliable data from the informant. But if it is some relative other than parents or family members, then we can say that okay, fine, or some or the other things the relative may not say, may not talk about, because he is not knowing, he is not staying with the patient all the time, or he is not looking after the patient. Fine, is in suppose there is a friend, so the friend might not be knowing everything about the patient. So on the basis of the relationship of the informant to the patient, then we say, we rule out that whether the information given is relevant or not, and whether the information is reliable or not. Can we rely on the information given by the informant completely or not? So in identification data, there is age, there is gender, there is occupation, there is education, marital status, dietary habits. Okay. And in the informant, whether the informant is reliable or not. Okay, so these are two components. Then next is chief complaints. Chief complaints are the problems, or we can say presenting complaints, the complaints with which patient came to the hospital. For example, there is a patient came to you and he said that he is having a problem in sleeping. He is not able to sleep properly. So patient is presenting himself to you with the problem of not able to sleep properly. Patient is having headache. Patient is having irritable mood. Say these three complaints patient is saying. So these are patient's chief complaints, main complaints. With these complaints patient has presented to you. So in this, the complaints with which patient has presented to you. See, if there is a chief complaint, suppose a patient is presenting with abdominal pain. Okay, so at the time of admission, or at the time of when the patient came in the emergency department, he might have abdominal pain. But after few hours, after administering medications, patient's abdominal pain may subside. But after investigations, now the diagnosis is something else. But chief complaint has been subsided because of the drugs or medications. So chief complaints are those complaints with which patient presents to you. And then we go to the history of present illness. Now we rule out, we further explore the history of present illness. Now, okay, patient is presenting himself with insomnia, with irritable mood, and with headache, loss of appetite. So all these patients, all these are chief complaints. Now we are going to explore further. Okay, from how many days you are experiencing this? Okay, from how many days you are not able to sleep properly? How many days you are feeling that your mood is becoming irritable? How many days you are not eating properly? And why all this happened? Whether this happened with some incidents, whether this has some relationship with some kind of incidents or not. And okay, were you having any kind of physical illness because of this? It all happened. So exploring further the present illness. Did you go to some other doctor? Then patient will start telling you that I had first of all had I experienced irritable mood, and then because of this irritable mood and insomnia, I went to so and so doctor, and there I took some medications, but it did not get relieved. So I again went to some another doctor, some homeopathy doctor, and then I did not get any relief. So I came here. So this is how patient can give data about his history of present illness, that I went to so many doctors, I went to homeopathy too, I did not get relief, and so I came here. So all these are telling you about this is all data which you are collecting under history of present illness. This is to be detailed, uh, collecting, exploring further, and starting from the beginning. Patient might say that the same thing happened 2 years back, and the same thing happened, then again it happened after 6 months. So all these things are coming under history of present illness. Then comes treatment history. Whatever treatment patient has taken, patient might tell you that I went to some other doctor or some other hospital, I got admitted there for so and so days, and then I came here. So all those comes under history of treatment history. Then we talk about past history, past psychiatric and medical history. So in this we collect past history. In past medical history, we will collect whether the patient had any kind of physical illness in the past, or any kind of surgery in the past. So under medical history, any physical illness, whether patient hospitalized ever in the past or not, and then any surgical history. Okay, then past psychiatric history, any episode occurred in past, any hospitalization was needed or not, any medication. So any diagnosed medical condition or any diagnosed psychiatric condition history will come here. And then we talk about family history. In this we try to assess the family dynamics, the relationship between family members, what kind of bond they share, and how many members are there or not, what is the patient's position in the family, how much the family members are how the family members are connected to the patient, and how they are affected, and how many earning members are there in the family, okay, whether the patient himself is the only earning member or not. So all these history we collect here, and in this family history we make family tree. We make some kind of shapes. In this we make family tree. So I want to tell you, and this is also called as pedigree chart. In this we use some symbols, some shapes to denote male, female, patient, brother, sister, wife, all these things. So let me tell you, this is male, this is female, this is known as pregnancy, this is known as relationship, this is a female died, this is a male who died, this is, if we put an arrow here, this means this is a male patient, this is a female patient. Okay, so this is denoted as male, female, pregnancy, relationship, male died, female died, male patient, female patient, and okay. Suppose now patient says that he is married. So this is the patient. This arrow shows that male patient, and he is married. This is his wife. They have a relationship. This line shows relationship. They have two kids. Elder one is a girl, younger one is a boy. And he says that his parents are also living with him. So his parents are living with him, but he said that his mother died. So this is a female. We show a female who died with this cross, and this is the patient, and this is wife. Okay, and this line shows relationship. Fine. Now, if there is in family, there is, suppose this line shows, this means that they're husband and wife, and this line shows extramarital affair, that the female has extramarital affair. This dotted line shows the relationship. And I talked about the family dynamics, the bond. So if we say that if we say that this, suppose this is the patient has a strong bond with the mother. So like this, we are going to show this with a dotted line. The bond will be denoted here. Okay, so these are some pictures, some symbols by which we denote family chart or pedigree chart. Two more things. This, a double line shows consanguineous marriage. Consanguineous marriage means marriage in the close relationships, and this means divorce. So these are some symbols, some signs. Now next is personal history. In this personal history, everything related to the patient will be asked, his habits and his his likes, dislikes, temperament, everything will be collected here. Perinatal history during pregnancy. The history will be collected from the mother, that whether during pregnancy everything was normal, everything was fine or not, whether mother suffered with any kind of infection or not, whether the family environment was conducive or not, the mother was happy, mother got a good atmosphere. So all these things, because they directly impact the development of a child. And then childhood history, whether the child achieved all the developmental, it is about developmental milestones, whether the child achieved all developmental milestones on time or not. So proper growth and development, behavior or habits during childhood, school age, at what age the child started going to school. Okay, in personal history, it is about habits, likes, dislikes, temperament, all these things. Perinatal history, mother, during pregnancy, about the diet, about the infections or complications, family environment, the medications. So all these things. Next is educational history. Educational status of the patient, play history, for this history can be collected from parents and teachers. And what type of play or what kind of play a child used to play, whether the child like team plays or not, and competitive plays or not. Then emotional problems during adolescence. So adolescent history is also important because it is a very sensitive age. So whether during adolescent any change in emotions or not. Okay, any emotional problem. The next is puberty. In psychiatric, we the history collection is done in detail. Every aspect is gathered and explored. Obstetric history, whether at the time of delivery something happened or not, complications happened or not, and whether the child was premature or low birth weight. Occupational history, what kind of job patient does, whether he keeps on changing the jobs or whether it is he's satisfied with the job or not. Sexual and marital history, if the patient is married, then how is the marital relationship with the spouse, and what is the how I mean gather data about sexual history too. And then pre-morbid personality. Pre-morbid personality means the personality before occurrence of the disease. So when the first episode of the disease occurred, so how what was the patient's personality before that? So this was about history collection. So in psychiatric, we collect detailed history, and these are the components. Now let us talk about mental status examination. Mental status examination is a tool by which, by using this, we assess mental state of any patient. There are different components in it, and by using these components, we assess a patient's mental status. Fine. So first component is general appearance and behavior. In this, the patient's general appearance and behavior is assessed. So what happens here? When you are approaching a patient, or you are sitting and you have called some patient to talk, and you can see that some patient is approaching or coming to you, so that time only you can assess patient's appearance, whether patient's appearance is appropriate or not, whether the patient's clothes are hygiene, whether the patient has maintained hygiene or not, patient's clothes are clean or dirty, or whether they are according to the gender, whether they are according to the weather or not. This might happen, this happens in case of psychiatric patients. They are not able to maintain their general appearance, and usually they are found to they can be observed wearing woolen clothes in summer, or in summer clothes, cotton clothes in winter. So their dressing is not appropriate, not relevant, not according to the weather. And they are found to be, they don't take care of their personal hygiene. This is a very common observation in mentally ills, that they do not take care of their personal hygiene. And facial expressions, whether their facial expressions are relevant to the topic you are talking with the patient, whether patient looks very angry, or maybe frightened or scared, or patient looks very calm, comfortable, or friendly. So what kind of expressions, facial expressions patient is having, whether patient is able to maintain eye contact with you when you are talking with the patient or not, and whether patient's level of grooming, with this we have already talked, whether patient is cooperative with you or not. If you are asking something, if you are asking that, okay, what is your name, okay, and what is your address, where do you live, so whether patient is responding to you, whether patient is cooperating with you or not. So you have to keep down, you will note down all these findings while you have assessed the patient. Then eye to eye contact, whether patient is comfortable talking to you, and whether patient is maintaining an eye contact to you with you or not. Psychomotor activity, whether patient is okay, his psychomotor activity is okay, normal or not, whether patient is having some purposeless or restless activities. So, see, you have called the patient to sit and talk, but patient is continuously moving from one corner to another corner purposelessly and restlessly. But because you insisted, because you told to the patient to at least 2 to 3 times to come and sit down, patient came, sat down, but still he got up and started moving again. And if you made the patient to sit, then patient will be making some kind of movements with the hands or with the legs. So whether the patient's psychomotor activity is agitated more or not, whether patient is hyperactive or normal, or patient is hypoactive, whether patient is having stupor, whether patient is sitting in just one corner and not talking anything, not doing, not walking. So these psychomotor activity also you have to observe here only. Posture and gesture, whether patient, when you are talking to the patient, what kind of posture patient is maintaining, whether patient is looking frightened, whether patient is maintaining an open posture or not, whether patient is maintaining a rigid posture or not. Okay, so these all observations we have to write here in general appearance and behavior. This is the first component. In this we observe only the appearance. Then second component is speech. Now you start talking to the patient. You have started collecting the data, or you have started talking about any of the topic. So you will see, you will note initiation, whether the patient has initiation or not. Initiation means starting some topic, starting to talk, or just, you are not, the patient is not initiating any talks. Reaction time, how much time patient is taking to react. You have asked the patient that what did you eat in the breakfast? Patient is just sitting, he is not responding. He's taking a lot of time to start reacting, to start answering the question. So that means patient's reaction time is more than normal. Patient is taking a lot of time to react. Rate, what is the rate? How, frequently patient is, if you have asked 10 questions, so how many questions the patient has answered? Volume, whether the volume is very low, you are not able to understand what patient is saying, or whether the patient is screaming and loudly patient is talking. Then tone, what is the tone, whether it is polite, whether it is gentle, or whether it is not. Then stream, it has relation with thought. What kind of thoughts patient is having, whether patient is having circumstantiality, tangentiality, or flight of ideas. I hope you remember these words. Circumstantiality means if you have asked a question to the patient, so patient, what patient will do, patient will give unnecessary details, and then in the end he'll come to the answer. Okay, so this is the A point and this is the B point. This is circumstantiality. Tangentiality, patient will never come to the answer. You have asked a question, but patient will never give the answer. This is the response, but these are not going to meet. Patient is not going to give the correct answer. Flight of ideas, patient, the thoughts in patient's mind are racing, they are flying. So the speech is also flying. So patient will be talking, but you will not be able to take out any meaning out of the patient, out of what patient is speaking, because patient's ideas are flying from one subject to another subject, and one topic to another topic. Then comes coherence. Coherence means fully coherent, whether patient's voice speech is fully coherent or loosening of association. It means coherence means there is, connection between words, and when usually when we have connection between the different words. We suppose I'm speaking a statement, I'm speaking a sentence. My name is Chetana. So these words which I spoke, these all have connection in between. They are coherent, they are clear. You can easily hear these words which I just said. So this is coherent. But if there is loosening of association, if these words are not associated with each other, then it will be called as loosening of association. And if these words are loose, there is no connection, then you will not be able to take out any meaning out of it. Then comes echolalia and neologism. Echolalia means when the person repeats the words spoken by another person, when the patient repeats those words, whether it may be the another patient, it may be family member, it may be the counselor, it may be the doctor or nurse. So patient repeats the words said by another person. Neologism, patient will say those patient will invent new meanings, new words, new names to the things and people. Patient will have some new meaning, sorry, new word for this pen. We call it a pen, but patient can call it with some another name, which the meaning of the word patient will only be knowing. So neologism. Next comes mood and affect. Now, mood and affect we had discussed in when we were discussing about mood disorders. But let me just recall it here also. Mood is something which we have to tell. Nobody can observe, and affect is something which one can observe on my face. If I say that I am not in a good mood, I am very angry today. So the same expressions I will be having on my face. Somebody by looking itself on my face, one can rule out that yes, she is not in a good mood. So let us don't talk to her. Okay, so this is the connection. There is always a connection between a mood and affect. But what happens in case of psychiatric patients? These two things become disconnected, or both of these things are not relevant to each other. Patient might say that he is in a very good mood, but at the same time, patient's affect will not convey the same thing. Patient might say that I am very angry today, or I am in a very sad mood, I want to cry, but at the same time, patient would be smiling or laughing. So there is these two things are not relevant, not appropriate. Now, it may be irritable, it may be labile. Labile means it changes very frequently. Blunted. Blunted means no expressions at all. Mask-like face. Anxious, fearful, panic, aggressive, and cheerful. So these all findings can be observed in this mood and affect. Patient may say all these things, and affect might demonstrate all these things. Then comes thought. In thought, there is three things, basically. Three components are there: stream, form, and content. In stream, flow of thought is observed, or flow of thought is checked. In flow of thought, there is thought block, clang association, mutism, and poverty of thought. So flow of thought means normally thoughts flow in our mind in a sequence, in a relationship, in a speed. But here, when stream or flow of thought gets disturbed, so we might have thought block. Suddenly, what happens? This we also experience many times. Suddenly, we try to say something, but in middle of the sentence we forget, and there is, we also stop talking, and we say, "Oh, I just had a thought block," which means my thoughts were blocked, and I could not complete my sentence. Clang association, when the patient speaks in rhyming words only. The words which have similar sound. Cat, bat, rat. Okay, so these kind of words patient speaks. The words which have similar sounds. And then mutism, patient doesn't speak at all. Poverty of thought, patient is not speaking much. Poverty of thought, nothing is coming in his mind. Patient may say that. Then second, after stream, second is form. What form of thought? What is the form of thought? So here circumstantiality may be there, tangentiality may be there, word salad and ambivalence. Word salad means, okay, all of you have seen salad, all of you have had salad, and you all eat it. So when we make salad, what we do, we cut different kind of vegetables, keep them together and make a salad. So can you give any particular name to those vegetables? Can you call it cucumber? Can you call it carrot? You cannot, because all things are mixed. We cannot give one particular name to this salad. So this also, the same thing happens here also. Word salad, patient mix different kind of words in a sentence, and nothing can be, there is no meaning of that sentence. Ambivalence. Ambivalence means when the patient has two contradictory wishes for same thing, same object, same situation, or same person. So what happens? These mentally ill patients, sometimes they have ambivalence, and ambivalence is one of the characteristic feature of schizophrenia, psychotic disorders. So what happens with these patients? Suppose these patients say they are going somewhere. Suppose there is a patient in the ward, and now patient wants to go to the washroom. So he just came out of his bed and he started walking towards washroom. He told his relatives or family members that I'm going to the washroom, or to this nurse that I want to go to the washroom. And he came out of his bed and he started walking towards the washroom. But then what happens? You are observing him, and suddenly in the middle way, he stopped and looked confused, and he is not able to. He's not able to decide whether he has to move forward or backward. So this is the meaning of ambivalence. They suddenly seem to be confused about one thing, whether to go, whether to move forward or whether to stay back. Okay, you go to the patient and you are greeting the patient and you want the patient to get involved in the recreational activities, or you might give as a pen and paper to the patient to draw something or write something. So patient will be looking confused, that patient will be having ambivalence, whether should I take this paper or not. So these patients, when they are experiencing ambivalence, they looked so confused and they are not able to decide. Basically, they are not able to decide what to do, whether to go to the washroom or to stay back, whether to take this pen and paper to draw the things or not. So they are confused. Then third is content. Content means delusions, ideas like worthlessness, hopelessness, helplessness, then thought alienation, obsessive compulsive phenomena, and phobias. So in thought, we have to rule out delusions. Now, how are we going to rule out all this? While talking only, you can observe that whether patient is having thought block or not. Patient will be speaking, and you can observe that whether patient is having clang association, mutism or not, circumstantiality, tendentiality. There is no need to ask any specific question for these answers. But in content, for delusions, patient may say this that while talking only you might get to know, but if the patient has not talked about it till now, so you can ask the direct question to the patient, or you can ask the family members. You will get to know the information. Now, for ideas, worthless, hopeless, helpless. Here also you can rule out. Patient may say these words that no, I'm not important for anyone, I am not good for anything, and there is no use of me, and my life has no use, or I'm useless. These kind of words patient may say, which reflects that patient is having worthlessness. Patient thinks that he is of no use, he is of no worth. Patient may seem hopeless when he says that everything is gone and now nothing is remaining, and nothing good can happen with me. So patient is hopeless, helpless. No one can help me. I will be like this only. I cannot be better. Nothing can help me. So these ideas will come under content. Then thought alienation. Thought alienation, in this there are three things: thought insertion, thought withdrawal, and thought broadcasting. Why it is called as thought alienation? Because it is a type of alien phenomena. Here patient says that in thought insertion, patient says that somebody else has inserted thoughts in my mind. Whatever I am thinking or whatever I am saying, these are not my thoughts. Somebody else has inserted them in my mind. Thought insertion. These are alien phenomena. That is why. Then second is thought withdrawal. Patient says that somebody has taken out thoughts from my mind. Somebody is stealing my thoughts. Somebody is withdrawing my thoughts from my mind. Then thought broadcasting. Suppose patient will say that suppose he sees that some news is there on the TV. So patient might say, this was my thought. They have stolen my thought and they have broadcasted my thoughts. Okay, so these are thought alienation, alien phenomena, and then comes obsessive compulsive phenomena. In this, there are images, there are doubts, thoughts which are repetitively coming in patient's mind, and patient wants to act on those thoughts. And then phobias, any kind of phobia patient may have. So this was about thought. In this, we talk about stream, form, and content. Now, next comes perception. In perception, there are hallucinations, illusions, deja vu, and depersonalization, derealization. Okay, illusions. How you are going to rule out illusions? While talking only, you can see that patient is having illusions. While observation. Okay, so illusions are disorders of perception where the person misinterpret or misperceive the stimuli present in the environment. Suppose patient might perceive anything lying on the floor or anything in the environment in some other thing. A classic example is patient might perceive a rope as a snake. So this is illusion. And hallucinations are of many types. Hallucinations are of audio, auditory, visual. Okay, hallucinations are illusion means misperception of stimuli. Hallucinations means perception or perception in absence of stimuli. There is nothing, but still patient is perceiving in absence of stimuli. And there are different types: visual, auditory, gustatory, olfactory, tactile. And if you ask about the most common type, then auditory is the most common, and after that, visual. Okay, now deja vu. What is deja vu? It is an interesting thing, you know. This happens with us also. Deja vu means sometimes we feel that whatever we are experiencing at this moment, this has already happened. This we have already experienced. So this is the meaning of deja vu. Something experiencing now, we have a feeling that we have already experienced it. We have already experienced it before. This happens with is with us also, but we are normal individuals. We are not having any kind of illness, so we are not disturbed with this. Our day-to-day functioning is not disturbed with this feeling. This might happen with us in maybe very rare, but with patients, deja vu might happen very frequently. Now, this depersonalization, derealization, this means feeling of unreality. Depersonalization, patient feels that he has now he has disconnected from his body. He has come out of his body, and he is watching himself from outside of the body. As we watch the movie, so he is also watching himself from outside of the body. Depersonalization. And derealization means patient feels that everything around him, everything in his environment has become unreal. It is just like dream-like and foggy. It has become everything looks like, dream-like. Okay, foggy and not clear, and everything is not real. So feeling of unreality. Patient will say that I feel as if I'm watching myself from outside of the body. Next is cognitive functions or higher mental functions. In this, we assess consciousness, orientation, and all these things. So consciousness, there is no specific question to be asked. We have till now we have already seen that patient is conscious. He is not unconscious, or he is not in coma or like that. He is conscious. Now, checking the orientation, we have to check the orientation, that whether the patient is oriented to time, person, and place or not. So for this, we need to ask questions like for checking the time, we need to ask that what is the time? Can you tell what is the time now? For place, do you know where are you right now? Which place is this? And person, you can ask about the person who is accompanying the patient, that do you know who is he or who is she? So So these type of questions can give us answer of orientation. If patient says that yes, uh, or season or month or weather, we all ask about in the orientation. If the patient is oriented to time, person, and place, we write oriented. Then attention. Now, for attention, we give patient task like we give patient to count the countings forward and backward, or we may say that uh, the names of months. We ask patient to tell the names of months in forward or backward um, manner. Or if the patient is not able to do that also, then we say patient to say this spelling forward and backward. Okay. Then concentration. For concentration, we give a small task to the patient. We say patient that you have to reduce 7 from 100 and keep on reducing it at least for 5 times, 3 to 5 times. So this is how we check concentration. And why we give only this number we have to give, 100 minus 7, because this is the number which is kind of requiring more concentration. If we say that reduce 5 from 100, so it is very easy. If we say reduce 2 from 100, it is also very easy. But this number 100 minus 7, this is universal task. These are the only numbers which are given in this component. And names of months or days backward. Then comes to memory. In memory, there are 3 types we check: immediate, recent, and remote. Immediate memory is just you say something to the patient and then you ask some other thing and then you tell patient, what did I tell you? Can you say? Can you tell? So immediate, within 5 minutes memory. Recent means you can ask that what did you eat in the dinner? What did you, last 24 hours memory is recent. Verbal recall. You can tell patients 3 or 5 names of unrelated things. You can say that I am going to tell you the name of 3 things. Remember those names. I will be asking you after some time. So you say that paper, table, apple. So 3 unrelated things you have to tell to the patient, and tell patient that remember these, I will be asking after some time. So after talking for a while, then you again ask that I told you 3 names, then what are those words? So if the patient is able to answer, then patient's recent memory is intact. And remote means past events, the date of marriage or the date of birth of the child. So all these things comes under remote. Personal information. Then comes intelligence. For checking intelligence, small simple arithmetic questions can be given or GK questions can be asked. Then abstraction. To check out abstraction, proverbs, the meaning of proverbs can be asked. Proverbs can be given and ask them to explain this. And similarities and dissimilarities. You can ask the similarities and dissimilarities between related objects. Like you can say, what is the similarity between a pen and a pencil? What is the similarity between an apple and a ball, an orange or a ball? So similarities and dissimilarities. Then judgment. Judgment in this, personal, social, and test judgment are assessed. We give some certain conditions to the patient and ask what judgment patient is making in those conditions. For example, we can say that, okay, fine. If after discharging from the hospital, what is your future plan? What are you going to do? First, then second, we give some situations like, okay, you are going on a road and you find a wallet lying on the roadside. So what will you do? If you are going somewhere and you see that a house has caught fire, so what will you do in that condition? So these kind of situations we give to the patient, because all these functions comes under cognitive function, higher mental functions. Then the last component is insight. Insight is graded from 1 to 6. Okay, so these all are the questions. These all are the levels of insight. You will ask, now what is insight? Insight is awareness, whether the patient is aware about his disease condition or not, whether patient has awareness about himself or not. So you will ask the patient that, why are you here? Do you know why are you here? Do you know the reason you are here? Okay, so patient might say that I don't know why I am here. I am all right. My family members have brought me here forcefully. So I'm all right. I don't have any problem. So this response of the patient shows that he is having complete denial about his illness. So this, if patient responds this, then the insight is 1. If patient says that, yes, I am sick, that is why I am here. So patient has slight awareness of being sick. I am not that much sick, I don't need hospitalization. I can be okay if I stay home. So if the patient is having slight awareness, then it is 2. Patient may say, yes, I am sick, but my neighbor has done something for this. My neighbor has done something, or because my family members don't like me, or because my family members don't take care of me. So external factors, attributing the cause on external factors. 3. Fourth is awareness of being sick but attributing to unknown factors. Yes, I know I am sick, that is why I'm in hospital, but I don't know why I am sick. So patient is not knowing patient says that unknown factors are there. This is 4. 5 is intellectual insight. Patient knows that he is sick, but there is no emotional component is there. Then it is 5. And then patient has true emotional insight is graded at 6. Patient says that, yes, I know I am sick, I am having this mental illness, and after taking, I have come here to take the treatment. After taking treatment and medicines, I will be better, and I have to, after that I will be discharged, but I have to continue my treatment for so and so, or the time or the prescribed dose or time or whatever. So patient has true emotional insight graded as 6. So this is about insight. So these are the components of mental status examination, MSc. First is general appearance. Second is speech. Third is mood and affect. Fourth is thought. In this, stream, form and content is there. Then perception. Then next is cognitive functions, and last is insight. Now next comes is mini mental status examination. This is particularly it is done to rule out cognitive disorders, and it has got maximum 30 score. There are certain questions which we ask from the patient, and on the basis of this we give them score out of 30, and then we say that whether the patient is having mild, moderate or severe cognitive decline. So the questions are like this. First we check the orientation. What is the year, season, date, day and month? For these questions, 5 marks are maximum 5 score is there. If the patient is able to answer these questions or any of the component he misses, then according to that patient score is given. Suppose patient has told that given the right answer about the year and season and month, he doesn't know about the day and date, then 3 score will be given. Now, where are we now? If patient says we're in hospital, which state, which country, which town, hospital or floor, then out of 5 maximum score is given. The examiner names 3 unrelated objects clearly and slowly, which I gave an example: pen, table and fruit or apple. Then the instructor asks the patient to name all 3 of them. The patient's response is used for scoring. The examiner repeats them until patient learns all of them if possible. So if the patient is able to recall all of them, then 3 will be given. If the patient forgets 1 or 2, then on that basis 1, 2 or 3 score will be given. Then next, I would like you to count backward from 100 by 7. So reducing 7. Then 100 minus 7 is 93. 93 minus 7 is 86. Alternative is if the patient is not literate, the patient is illiterate and cannot do that. So alternative is spell world backwards. So if the patient has done it, is able to do it for 5 times, then 5 score will be given. And if the patient has done it completely, all the alphabets he is able to spell backward, then 5 score will be given. Then next is, earlier I told you the names of 3 things. Can you tell me that? Those were? So this, see, verbal recall. This is verbal recall. Telling 3 names of unrelated things and then telling the patient to recall. If the patient is able to recall all 3 of them, then 3 score will be given. Show the patient 2 simple objects such as wristwatch and a pencil. Ask them to name them. Ask the patient to name them. We show patient some objects and tell the patient to name them. If the patient has done it, then 2. Maximum score is 2. Then repeat the phrase, no ifs, ands, or buts. We give patient some phrases to repeat. If the patient is able to repeat, then 1 mark is given, 1 score is given. Take the paper in your right hand. These are some verbal commands. Take the paper in your right hand, fold it in half, and put it on the floor. The examiner gives the patient a piece of blank paper. So we give a piece of paper to the patient and we give instructions. We tell, take the paper in your right hand. First instruction. Second is fold it in half, and third is put it on the floor. If the patient has done all 3 of them, then 3 score is given. Please read this and do what it says. Written instruction is close your eyes. You are giving a piece of paper to the patient. On that paper you have written close your eyes, and now you are instructing patient by handing over the paper to the patient that read the instruction and do it, follow it. So if the patient has done that, then 1 score is given. Make up and write a sentence about anything. You are asking patient to write a sentence about anything. Please copy this picture. The same picture, patient has to copy this picture. The examiner will draw and show to the patient, and now patient has to copy this picture. If all 10 angles must be present and 2 must intersect. All 10 angles must be present and 2 angles must intersect. So if the patient is able to draw this, then 1 score is given. Total is 30. Now let us talk about the range. Range is if it is 0 to 17, 18 to 24, and 25 to 30. It shows normal, moderate, and severe cognitive decline. So, normal or maybe mild. So, if the patient's score is 25 to 30, then it is mild. If it is 18 to 24, then it is moderate cognitive decline. And if it is 0 to 17, then it is severe cognitive decline. So this is the interpretation of mini mental status examination. It is particularly done for the patients who are having cognitive decline, the patients who are having any kind of neurological condition, or the patients who are having dementia, delirium, amnesia. So for those patients, this is done. Actually, 25 to 30 is normal range. If the patient score is from 25 to 30, it is normal range. Then 18 to 24 is moderate, and less than 17 is severe cognitive decline. So this is all about the history collection, mental status examination, and mini mental status examination. I hope you understood this. Okay, then next is neurological examination. Neurological examination has got certain components, again, just like MSc, mental status examination. So first is identification data and then mental status examination.